Welcome to ATCM, the Emergency Medicine channel. Today let us discuss about pancreatitis. Pancreas is a major organ in our body. It has got both exocrine and endocrine functions. In exocrine function, it has got various enzymes like lipase, protease, amylase. All these enzymes try to break down carbohydrate, protein, fat, and it creates energy, or it helps in energy production in our body. Endocrine functions are like the pancreas can release insulin and glucagon. We know that insulin and glucagon maintains our sugar balance, and somatostatin is another hormone. It has got various other functions, and other than that, it even regulates the insulin and glucagon secretions. Now, this is the anatomy of pancreas. You can see the pancreas, pancreatic duct, blood vessels which supplies the pancreas, the endocrine and exocrine glands, bile duct. It all drains to the duodenum, intestine. Pancreatitis means inflammation of pancreas. It can be acute pancreatitis, chronic pancreatitis, acute on chronic. It can be infectious, non-infectious, obstructive, various causes also there. So pancreatitis means inflammation of pancreas. There are various causes for pancreatitis. In that we will see only acute causes. Gallstones, one of the common cause. Alcohol, that is also very common in our country. Infections like viral infection, mumps, Coxsackie B virus, tumors of pancreas, drugs like azathioprine, estrogen, corticosteroids, many anti-HIV drugs, all can produce pancreatitis. The list of drugs are very big, so that we are not able to involve in these slides. Then post-surgical or ERCP procedure sometimes can produce pancreatitis. Very high triglycerides can produce pancreatitis. Trauma, blunt trauma to abdomen. Idiopathic, that means without any cause. Chronic, again, alcohol, tropical pancreatitis, hereditary, protein defects, cystic fibrosis, hypercalcemia, trauma, idiopathic. So these are the causes for pancreatitis. In that, two important causes we should remember. One is gallstones, other one is alcohol. Now again, these are the causes. Common causes for acute pancreatitis. The commonest cause is gallstone and then alcohol. These are the two important causes. Others are not very common, but they are also can present to emergency room with severe abdominal pain. When we discuss about the clinical features, these patients present with severe epigastric pain and radiate to back. Pain radiates to back. On examination, you can get generalized tenderness or only epigastric tenderness. If it is only pancreatitis, epigastric tenderness. If it is a peritonitis secondary to pancreatitis, general tenderness can be there. Patients who is having gallstone induced pancreatitis, pain is well localized to the epigastrium and right hypochondrium, whereas pancreatitis due to hereditary or metabolic causes or alcohol, the pain is abrupt and sudden onset, and pain may be poorly localized. Jaundice can be there in some patients who is having edema in the head of the pancreas and obstruction to the bile duct. Left-sided pleural effusion and pericardial effusion can be seen in many patients. So this will be the clinical finding: severe epigastric pain and tenderness on the epigastric area. It may radiate to the pain may radiate to the back. There are two important signs which are seen in patients who is having very fair skin and those who are not received any treatment initially. Cullen sign and Grey Turner signs. You can see the Cullen sign, there is faint bluish discoloration around the umbilicus. Grey Turner signs is bluish discoloration of flanks. So these are the two important findings you can get in pancreatitis, not very commonly seen, but many patients who is having fair skin you can get this. Now, according to Atlanta classification, acute pancreatitis can be divided into two important classes: interstitial edematous acute pancreatitis and necrotizing acute pancreatitis. Acute inflammation of the pancreatic parenchyma and peripancreatic tissue, but without tissue necrosis, only inflammation is there. There is a first class. Necrotizing means there is necrosis, cell death, and it may lead to peritonitis. According to severity, pancreatitis is divided into mild, moderate, and severe. So, various types of classifications are available depending on the various clinical presentations. Now, we will see what are the predictors of severity in pancreatitis. Age is an important factor. Old age, very bad prognosis. Alcoholic pancreatitis, bad prognosis. Short time interval to symptom onset, very bad prognosis. Obesity, again bad prognosis. Organ failure is very, very bad prognosis. So, pancreatitis with multi-organ dysfunction syndrome is having very, very bad prognosis. Other lab investigations also can predict severity. One important factor is hemoconcentration. We know that pancreatitis can produce acute fluid loss. Fluid loss can be to the third space or intra-abdominal fluid loss. That will produce hemoconcentration that with high hematocrit. That's a very bad prognosis. Elevated CRP, like any other conditions, wherever there is acute inflammation, CRP will be elevated. In severe pancreatitis, CRP levels will be very high, more than 150 milligram per liter. So that's a very bad prognosis. Increased blood urea nitrogen, that means urea is elevated. That indicates again hemoconcentration, reduced intravascular volume, reduced blood supply to the kidney. Urea can be elevated. It indicates pre-renal failure. It's a very bad prognosis. Serum creatinine, again elevated serum creatinine in first 48 hours indicates very bad prognosis. Like any other organ dysfunction, creatinine is also very important. Creatinine can be affected in two ways. One is pre-renal failure, other one is directly due to the toxins it can be affected. Pleural effusion, lung infiltrates, ARDS, all these things also have very bad prognosis. Now we will see what are the basic investigation you do in a suspected case of pancreatitis. In that, most important things are amylase and lipase. Amylase is elevated threefold in pancreatitis in most of the cases, and it has got a sensitivity of 67 to 83 and specificity of 85 to 98%. It can also be elevated in many other conditions like salivary gland inflammation, infection, liver injuries, small intestine injuries, kidney damage, fallopian tube damage, carcinomas of lung, esophagus, breast, ovary. So this is not very specific for pancreatitis. It can be elevated in pancreatitis, but it can also be elevated in other conditions also. So specificity, sensitivity is 67 to 83 and specificity is 85 to 98%. But lipase is more sensitive and it is more sensitive and specific than amylase. Positive in 70 to 85% of the cases, and sensitivity specificity is 82 to 100%. So it's highly sensitive and highly specific for pancreatitis. Amylase tend to elevate in gallstone pancreatitis, whereas lipase is higher in alcohol associated pancreatitis. Whatever it is, lipase is more specific factor than amylase for pancreatitis. Other investigation we have already seen, there will be hemoconcentration, hematocrit can be elevated, peritoneal pleural fluid lipase can be elevated, WBC count can be elevated, CRP can be elevated, X-ray abdomen chest, it can rule out perforation like gas under diaphragm can be ruled out, pleural effusion can be ruled out, USG again gallstones, pancreatic swelling, peripancreatic collections, abscess, all these things can be ruled out by USG. CT again very important, contrast enhanced spiral CT will pick up pancreatic swelling, pancreatic necrosis, peripancreatitis collection, and cyst, pseudocyst. All these things can be ruled out by CT. So USG, you can see bulky non-homogeneous pancreas with presence of peripancreatic fluid that indicates pancreatitis. CT abdomen also you can see pancreatic enlargement, pancreatic inflammation with infiltration of edema. There is a severity index according to the CT scan. This is a sum of two scores. One is Balthasar score, another one is grading the extension of pancreatic necrosis. Balthasar score is normal pancreas is 0, enlargement of pancreas 1, inflammatory changes in pancreas, peripancreatic fat 2, ill-defined single peripancreatic fluid collection 3, 2 or more poorly defined pancreatic fluid collection 4. This should be added with the pancreatic necrosis scoring. No necrosis 0, less than 30% necrosis 2, more than 30% to 50% 4, more than 50% 6. Maximum score can be 10. 0 to 3 mild acute pancreatitis, 4 to 6 moderate acute pancreatitis, 7 to 10 acute severe pancreatitis. So this is CT severity index. So that can be done by a CT scan, contrast enhanced CT scan. You can pick up the pancreatic inflammation and necrosis. Another criteria to predict severity is Ranson's criteria. That depends on various other factors like age more than 55, WBC count more than 16,000, blood glucose more than 200, lactate dehydrogenase more than 350, LDH, aspartate aminotransferase AST, liver enzyme more than 250. After 48 hours, hematocrit concentration, that hemo concentration, fall by more than 10%, blood urea nitrogen increased by 5 mg per deciliter, serum calcium less than 8 mg per deciliter, PO2 less than 60 mm of mercury, base deficit more than 4 mg per liter, fluid sequestration more than 6000 ml. So this also predicts the mortality in patients who is having pancreatitis. This is called as Ranson's criteria. Mortality increases with increasing in the score. Okay, when the score is very high, mortality is very high. Now, when a patient admitted to ER, which all values or which all indicators are there to admit this patient to ICU? That is very important. Some patients may require ward admission only, some patients may require ICU admission. So if the pulse is very low or very high, admit to ICU. BP is very low or very high, admit to ICU. Respiratory rate more than 35, admit to ICU. Sodium very low, less than 110 or very high, admit to ICU. Less than 110 means it's a dilutional hyponatremia or sodium loss, whereas very high sodium indicates severe dehydration. So there also we have to admit to ICU. Potassium low or high, admit to ICU. PO2 less than 50, pH very low, less than 7.1 or more than 7.7, serum glucose more than 800, serum calcium more than 15, anuria, coma. So whenever patient is having abnormal, very abnormal lab results other than routine amylase and lipase, so these patients may deteriorate very fast, so better to admit them in ICU. Now, one of the important management in pancreatitis is, we know that pancreatitis means inflammation of pancreas. It can be infectious, non-infectious. But the problem in pancreatitis is they lose large amount of volume from the intravascular compartment. That is creating all other systemic complications. So replacement of fluid is very, very important. We can use either ringer lactate or normal saline. Both are equally effective. But in lactic acidosis with liver disease, avoid ringer lactate. Otherwise, in all conditions we can use normal saline or ringer lactate. So 20 ml per kg fluid over 30 minutes followed by 3 ml per kg per hour or 8 to 12 hours. We have to see patient's heart rate, BP, pulmonary edema features, urine output, capillary refill time, IVC collapsibility. All these things should be examined and fluid should be replaced according to the fluid deficit and improvement in the systemic circulation. Whatever it is, fluid management is one of the most important management plan in pancreatitis. Another important plan is they will have severe pain. So many drugs are not safe in pancreatitis, like morphine is relatively contraindicated because of it contracts sphincter of body. But it's more of a theoretical problem. However, we don't try morphine in this type of patients. We go alternative drugs like fentanyl, pethidine, tramadol. So that can be tried. Antibiotics are not really indicated in pancreatitis because we have seen the reasons for pancreatitis. Most of them are not infectious. But a patient who is having an infectious pancreatitis or patient developed secondary peritonitis in pancreatitis, they may require antibiotics. Otherwise, just to prevent infection, you can give an anaerobic coverage, like you can give cefotaxime, ceftriaxone or metronidazole, whatever it is. But if the patient is having a strongly suspected infection, bacterial infection, you can go for procalcitonin. If the procalcitonin is high, that indicates a bacterial infection. Then we require to give a higher antibiotic like imipenem cilastatin. There is one of the best drug which can be given in pancreatitis. 1 gram IV TID is the usual dose of secondary bacterial peritonitis in pancreatitis. But basically, pancreatitis does not require any antibiotic. Now, calcium correction is very important. Calcium and magnesium should be checked frequently every 48, 80, 72 hours because we are giving aggressive fluid correction. Hypocalcemia can occur early. So, all these things should be corrected. So, hypocalcemia should be corrected as soon as possible. Hypomagnesemia also can be there in some patients. Blood sugars are very important. Many patients with pancreatitis can have high blood sugar also, and diabetes is one of the most important conditions where the pancreatitis creates a lot of complications. So blood sugar should be tightly controlled and it should be less than 180 in ICU. Nutrition, very important. Previously it was told that we should not give any oral feed to the patient, but now the guidelines are slightly changed. Enteral feeding can be started within 24 hours of admission following initial period of volume resuscitation and after controlling the nausea and pain. So that is important. If the patient is having pain, we will not be able to feed the patient through the oral route. Then we have to go for parenteral replacement of nutrition. But if the patient does not have pain, we can start fluids as an initial diet plan. Then we can slowly increase the diet, but try to avoid fatty food, because fatty food again it can create some more inflammation in the pancreas, because the pancreas has to overwork there and pancreatic pain can be induced by fatty food. So that is a major change from the previous guidelines. We can feed the patient as soon as possible if the patient is having able to take orally and there is no abdominal pain. Immediately within 24 hours we can start the oral feeds. Now there are a lot of complications which can produced by pancreatitis. Septicemia is one of the important complications. Septicemia, multi-organ dysfunction that can lead to death. Peritonitis, again pancreatitis can produce peritonitis because of chemical spillage over the abdomen. So it's chemical peritonitis. Ascites and left-sided pleural effusion can be there in many patients. Pancreatic pseudocyst formation is an encapsulated collection of fluid with well-defined inflammatory wall, usually outside the pancreas with minimal or no necrosis. pancreatic abscess can occur. Multi-organ dysfunction can also be produced by pancreatitis, especially like ARDS, renal failure, myocarditis, pericarditis. All these things can occur in pancreatitis. Now, interventions. There is very limited scope for intervention in acute pancreatitis. We will not be able to touch the pancreas because it's highly inflamed and it may produce complication. But in a patient who is having pancreatic cyst, pancreatic pseudocyst, or gallstones, abscess, necrosis, peritonitis, all these things, we may require a surgeon's help to manage this case. Another important procedure is ERCP, endoscopic retrograde cholangiopancreatography. The main role of ERCP in acute pancreatitis is the diagnosis and treatment of biliary tract stones. So that in that condition, that stone induced pancreatitis, this will be very helpful. It can relieve the symptoms very fast. Otherwise, these investigations and management things or surgical management is not very useful in acute pancreatitis. Now you can remember the treatment of pancreatitis like this. Pain management is very important. We can give fentanyl, avoid morphine. Antispasmodic drugs can be given in many patients who is having pancreatitis can have spasmodic pain that can be controlled. NPO is not required after 24 hours. Initially we have to keep the patient NPO. Rayleigh tube aspiration can be tried. So there will be a severe electrolyte imbalance that has to be corrected. But after 24 hours, if there is no pain, if there is no vomiting, we can start the oral feeds as soon as possible, but try to avoid fatty food. Calcium to be corrected in patient who is having initial hypocalcemia. Hypocalcemia is seen in initial phase of pancreatitis, so that has to be corrected. Whereas hypercalcemia sometimes can produce pancreatitis, so that also should be corrected. Replace the fluid. IV fluid initially start 20 ml per kg bolus, then infusion should be continued. We have to follow up the patient's urine output and IVC collapsibility, urea, sodium, all these things has to be checked, and you can correct the fluid deficit. Intravascular volume loss is very common, but this volume is shifted to third space, not externally. So we have to be very careful when we give initially fluid. There will be intravascular compartment will be full after giving normal saline and ringer lactate. Afterwards, that fluid also will be shifted to this third space if the inflammation persisting. So some of these patients may require continuous IV fluid treatment. ERCP can be tried in gallstone induced pancreatitis. Antibiotics are not really required in pancreatitis because it's only an inflammation, whereas secondary complication like peritonitis, abscess formation and all, we require antibiotic. Imipenem cilastatin is one of the best drug antibiotic of choice in pancreatitis. Continuous nasogastric suction can be tried initially, but throughout many days it may not be required. First 24 hours you may have to try it, but during that period patient can develop a lot of acid base imbalance, hypokalemia, that also should be corrected. So we have discussed about one of the most important emergencies, that is abdominal emergency, that is pancreatitis. So we have seen what are the causes which can produce pancreatitis. We have to understand it is not an infection, it's only an inflammation. So time is required to relieve the symptoms. So if we give time without any major treatment itself, pancreatitis can come down. We have to follow up the patient whether the patient is developing any complications or not. Thank you.